Chemical dependency counselors do not prescribe, adjust, or dispense medication, yet a profound understanding of pharmacology is required to do the job effectively. Clients enter treatment taking a variety of prescribed and illicit substances. They rely directly on their counselors for accurate education about how these drugs interact and affect their bodies. When a counselor can accurately educate a client on their prescriptions, support their adherence to the medical plan, and push back against systemic stigma, they bridge the critical gap between clinical intent and actual recovery. This knowledge also enables the counselor to speak the same language as the medical team, allowing them to spot and communicate early physical warning signs before they escalate into emergencies. But there is a strict boundary constraint. The counselor must know exactly where their clinical authority ends. The guiding rule is integration. Medication works best alongside psychosocial counseling, and that counseling must actively account for the client's medical plan. True clinical support means reinforcing the prescriber's strategy and bridging the gap for the client, without ever crossing the line into writing the prescription. To understand how these medications work, we must look past the liquid in the vial and examine the microscopic biological mechanics happening inside the brain. This diagram illustrates an agonist, a substance that locks into a cellular receptor and fully activates it. Heroin and methadone operate like this. By contrast, an antagonist completely blocks the receptor, wedging itself in and physically preventing agonists from attaching. Medications like naltrexone and naloxone are opioid antagonists. Between these extremes is the partial agonist. It activates the receptor but hits a hard biological limit, a ceiling effect, preventing further activation. Buprenorphine is the primary clinical example of a partial agonist, providing enough activation to relieve withdrawal without maximizing the receptor's output. The duration of these effects is governed by half-life, which is simply the time it takes for exactly half of a drug's volume to clear the human body. These specific cellular interactions and clearance rates dictate exactly how long a client will experience intoxication and precisely when their withdrawal will begin. Over time, the body adapts to these chemical inputs. Tolerance develops when a person biologically requires a steadily increasing volume of a substance to achieve the original baseline effect. Physical dependence is a separate internal adaptation. Here, the body has adjusted so heavily to the drug's presence that removing it forcibly triggers withdrawal. Building tolerance to one specific drug can also automatically confer tolerance to other drugs within the same class, a process known as cross-tolerance. Mastering these specific adaptive concepts allows a non-prescribing counselor to follow complex clinical conversations with doctors and translate those realities accurately to their clients. Applying these core concepts means recognizing how different psychoactive drug classes behave, specifically mapping their intoxication profiles and withdrawal dangers. Central nervous system depressants, like alcohol, benzodiazepines, and barbiturates, slow down brain activity. They cause sedation, muscle relaxation, and impaired judgment. The withdrawal from depressants is an acute medical danger. Abruptly stopping alcohol or benzodiazepines can cause fatal seizures and severe delirium tremens, mandating a strict medically supervised detox process. Opioids, which include heroin, fentanyl, and prescription pills, provide intense pain relief and euphoria. However, they also heavily suppress breathing, making respiratory failure and overdose a lethal leading threat to anyone actively using. Opioid withdrawal produces intensely uncomfortable, flu-like physical distress. While it is rarely fatal on its own, the severe physical discomfort makes it a primary biological driver of relapse. The hidden danger occurs after a period of abstinence. Because the body's tolerance has fallen, the risk of a fatal overdose exponentially spikes if the person returns to their previous dose. Stimulants like cocaine and methamphetamine operate differently, heavily accelerating the nervous system. Their withdrawal profile is intensely psychological, marked by severe fatigue, depression, and paranoia. Cannabis creates a distinct withdrawal syndrome that is frequently overlooked. Chronic users often experience high irritability and severe sleep disruption when they stop. Other classes present varied threats. Hallucinogens distort cognition, inhalants carry extreme chemical toxicity, and nicotine remains highly addictive and a leading cause of preventable death. The clinical objective here is not to memorize every chemical detail. The goal is to accurately triage which substances pose life-threatening medical withdrawal risks and which present distinct psychological hurdles in early recovery. We can apply our understanding of receptor mechanics directly to medications for opioid use disorder. These are the most thoroughly evidence-based interventions available for reducing illicit use and preventing overdose deaths. Methadone functions as a full opioid agonist. When dispensed at stable doses in a clinic, it keeps the receptor activated enough to prevent withdrawal without generating the highs and lows of illicit use. Buprenorphine, however, acts as a partial agonist. Because of its biological ceiling effect, it significantly lowers the risk of respiratory depression, making it safe enough to be prescribed in standard office settings. Naltrexone is a pure antagonist. It provides an absolute opioid blocking function, but requires the patient to be completely detoxified before starting, or it will immediately precipitate withdrawal. Naloxone, commonly known as Narcan, is also an antagonist, but it is not a long-term treatment. It is an emergency tool designed solely for rapid overdose reversal. Understanding these biological mechanics helps dismantle the persistent, harmful myth that these medications merely substitute one addiction for another. They normalize brain function so the client can safely parent, maintain employment, and actively engage in therapy. The counselor's duty is to combat systemic stigma, help clients navigate medication-friendly support structures, and coordinate care with prescribers without ever voicing personal opinions against the medical plan. For alcohol use disorder, 3 main medications are utilized. Naltrexone and acamprosate help stabilize disrupted brain chemistry, while disulfiram provides an external barrier by causing an immediate, severe physical reaction if alcohol is consumed. Managing medications becomes highly complex when clients in recovery also live with chronic pain. Untreated pain is a severe relapse trigger, yet utilizing opioid pain management is inherently hazardous for anyone with a history of addiction. The integrated medical approach to this tension strictly prioritizes non-opioid medications alongside non-pharmacological strategies like physical therapy and behavioral management. The counselor takes an active role here by communicating the client's recovery status to the medical team and teaching the client behavioral pain coping skills. While the counselor must never advise a client to start or stop a specific pain medication, maintaining that strict boundary while remaining an active advocate is a core professional competency. This need for integration extends to co-occurring disorders, which occur when a substance use disorder intersects with a mental health disorder, a reality for roughly half of all clients. Modern care is built on a foundational principle: both disorders must be treated as primary conditions simultaneously. The historical approach of treating one before the other routinely left patients falling through the cracks. Clinical assessment in these cases must be ongoing. Substance intoxication and withdrawal often mimic independent psychiatric symptoms, requiring time and observation to differentiate. This prevents a dangerous diagnostic error, mistaking genuine psychiatric symptoms like a depressed flat affect, avoidance, or severe impulsivity for a client's resistance, denial, or a bad attitude. The counselor's scope in these cases involves performing ongoing screening, referring the client for psychiatric diagnosis, supporting their medication adherence, and ensuring they receive a unified message from the entire care team. Operating effectively in addiction treatment requires a clear understanding of what a counselor must do: educate accurately, support medical adherence, reduce stigma, and recognize medical warning signs. It also requires knowing the strict prohibitions. Counselors do not diagnose medical conditions, they do not recommend specific medications, and they never advise adjusting doses. Advising a client to ask their doctor to switch their medication violates this boundary. Ensuring the prescriber knows about a specific side effect the client reported stays perfectly within it. Possessing the pharmacological depth to be useful to a medical team, while knowing precisely where that authority ends, is a core professional competency.